Good afternoon, AVA attendees. Is everyone having a good time? Great conference so far? Some awesome energy and engagement, so it's been fun. My name's Sarah Owens, and I work for PDI as the Clinical Programs Manager. And we are excited to have a presentation for you regarding our Prevantics device swab. This is a product that we're really proud of, and we have the luxury of having 3 speakers here today to help share their experiences with the product and provide you with some of their abstract and data information to help support our product. You've probably seen, if you were able to stop by our booth, the Prevantics device swab is to be used on needleless access devices. It is the only FDA cleared product that is 3.15% CHG and alcohol to be used on needleless access devices. So I know we have limited time here. If you guys have questions, if you'll hold them till the end, and then you can address the speakers, and just make sure you make your way up to the microphones if you do have any questions at the end. So I'd first like to introduce our first speaker, Dr. Peggy Callowes. Peggy is the Director of Nursing Research, Innovation, and Evidence-Based Practice at Memorial Care Long Beach Medical Center and Miller's Children's and Women's Hospital. Dr. Callowes received her doctorate of philosophy in nursing at the University of San Diego, and she established the Center of Nursing Research and Innovation, where nurses at all levels of practice can seek support to conduct research and evidence-based practice projects. She oversees over 40 nursing research and interdisciplinary studies. Please help me welcome Dr. Peggy Callowes.
Thank you, Sarah. Well, I'm very excited to be here today and share our work at Memorial Care, and I know you'll be impressed with all of our presentations today because we're all here to share our findings, and we're all here to really look at innovation to prevent catheter-related infections. So I'll kind of tell you about our journey. So probably this is our team, and we conducted a 6-month trial, as Sarah mentioned. And I'll tell you a little bit about the background heading into our study. We were becoming very, very frustrated. Long Beach Memorial Medical Center is a 569-bed trauma center, level 3 NICU and pediatric hospital as well. And we have a large oncology, pediatric oncology, and adult oncology services. And we were continuously above the benchmark in CLABSIs, probably for about 3 years in a row. So we tried all kinds of strategies from 2010 to 2015, and we just weren't getting below and getting close to zero. Over the last couple of years, we tried, our last strategy was adding the Kuros to our evidence-based practice using a bundle. Like all of you, we added VAD champions, you name it, we've added it. And so one of our VAD leaders attended the conference about 2 years ago and really met up with one of the PDI specialists and brought back the Prevantics information, and I said, whew, let's really look at this. The literature was really good, but being the scientist I am, I wanted to really test the product ourselves. So I'm going to share with you our trial and our significant findings. So really, we hypothesized in this trial, and this was a 6-month crossover trial, we were really hoping and hypothesizing that we would reduce our CLABSI rate by 50%. So we had a prospective design, and it was a non-experimental design. It was done in 2 phases, and we did it in our pediatric oncology unit and our adult oncology unit. Across our hospital, our rate was somewhat under the benchmark, but it too was not where we wanted it to really be. But our targeted units, which had the highest and highest risk patients for CLABSI, were among our oncology units. So at that time, our standard of care was the Kuros, and we used the alcohol, 70% alcohol pad. So for the first 3 months, and our nurses were really tied to the Kuros cap, and we used the alcohol pad. So we said, okay, for the first 3 months, we were going to continue to use the Kuros pad, or the cap, and then we would trial the Prevantics device pad. And then the last 3 months, we used just the Prevantics alone. And our endpoints that we were measuring, obviously, were CLABSIs we measured by month. And so it really was looking at a whole 6 month of incidence. So here's our results, which I hope that you'll be as impressed with as we are. And we're really about almost 1.5 years out from our original trial. So we had a total of 243 patients in our trial, 93 patients in our peds, and 150 in our adults. And we had about 5,302 patient days across both units. And then you can see the age groups. And again, our CLABSI prevalence went from 13 in the previous 6 months before the trial down to 5 in the 6 month trial. And the rate decreased from 1.1 line days from baseline of 3.2 and from a baseline of 3.2 in peds to 1.3 in adults, or down to, 1.3 in adults down to 0.83. Overall, we decreased our CLABSIs by 61%. And so you can see, and what the other thing we were looking at was, would we see any change in that rate if we remove the Curos? And there was really no significant difference in CLABSI rate at all after we removed the Curos. So you can see from our graphs, so in the middle, whoops, let me see if this is, oh, well, that did it.
Just hit it again.
Yeah, thank you, sorry. So, you can see right in the middle is our trial itself with the pre-trial data and the intervention and the post-trial. And so what we really looked at, so in 2017 was our post-trial in the January period, so we monitored all the way through 2017 and continued to hover around 0. And in 2018 is the end where you can see, let's see if I can not turn it off again, through here, through the summer. So in all areas, we have hovered under the benchmark. So, but, you know, surveillance, continuous surveillance, continuously working with the staff, continuously auditing the units to make sure they're adhering, obviously, to our baseline and our guidelines as well. So our conclusions and one of our great findings, again, we talked about the significance, but our sustainability we're really proud of. The other important thing about this is the cost savings related to this trial. During that period, we saved, just from removing the Curos and other supplies, over $409,000. And we have implemented this across our healthcare system, and we have saved over $1 million in cost avoidance with CLABSIs and supply chain alone. So you can see by just really monitoring and using best practices how we can make a difference in practice and really provide better care for our patients and avoid harm and injury and understand that. One other thing I'd like to share too, as we implemented the Prevantics Swab, we know we changed from the practice of 30 seconds, the 15-second wiping and the 15-second dry, to the 5-second and 5-second, and we costed out how many minutes that saved for nursing time, and it costed out to about 1 FTE of nursing time. Our nurses really saw that as more time to spend with their patients. We weren't fortunate enough to really get another FTE, but they really saw the difference. So they really are meticulous in utilizing and applying the Prevantics Swab properly, and we know that's really made a difference in patient care. Thank you very much, and I think we have time for questions afterwards. Yeah. Thank you.
Thank you, Peggy. So our next speaker today is Robert Marty Cooney. Mr. Cooney is an infection preventionist and infection control officer for UNC Rex Healthcare in Raleigh, North Carolina. He received his master's in public health from the University of New England. He's board certified in infection prevention and control and has recently completed a 3-year term as a board member for the North Carolina APIC chapter. Please welcome Marty Cooney.
Thank you very much. And thank you, everybody, for being here with your valuable time. We definitely appreciate it. We're all on the same page, wanting to reduce infections, especially involved with collapses, because they have detrimental outcomes on patients. So getting into this, we did a study. This is the second of two studies here. This one's the use of 3.15% chlorhexidine gluconate, CHG, and 70% alcohol hub disinfection to prevent collapses in the hemodialysis patients. So when you think about bacteria, the bacteria is everywhere. It's on the surfaces, it's on people's hands, it's on the visitors, it's on the patients who you may have seen picking at lines and pulling at things and stuff like that, and you see brown on their nails. You don't have to culture that to understand really what that can be, and that can be very detrimental if it gets into a patient's bloodstream, for sure. Sorry about that. There we go. So when you look at the risk in dialysis patients, and there's nearly 37,000 bloodstreams that occur yearly in these particular patients, and you say, well, what's the big difference a dialysis patient and a patient on an ortho floor or a patient on a different floor? These particular patients, they're in and out weekly, multiple times, 3-4 times a week, having their lines accessed continually. So you can see, as an infection control personnel, you can see the risk of infection would greatly increase in that particular population. And then when you think if they get the infection itself, what happens? It's not just blood in the urine and you give them antibiotic and everything's better. 25% of those patients, according to the CDC, will expire. That is absolutely awful. So you definitely don't want that to occur. They can have other effects such as acute kidney injury, which of course has a $6,000 to $8,000 cost associated. They could have a C. difficile infection with the antibiotics that they're given to treat. So then that could be $8,000 to $12,000 cost. Lots of literature out there to talk about that. So you don't want these patients to get that, and of course that increases morbidity and mortality. So once a patient has a line, they have a device, what's going on with how we can help prevent these things from happening? Well, when you look at the key influencing factors, ineffective hand hygiene, of course. How many of y'all have seen people wash their hands for as long as they're supposed to wash their hands for, 15 seconds? It doesn't happen too often when you really start stop clocking people. Hub contamination, as I said, patients will pick at their lines. Visitors will come in, what's this right here? Things can happen, and if you got there's studies out there publishing up to 30% of gross organic material and things left on lines that could easily happen in patients laying in beds day after day. Education be a factor of people handling different lines, patient manipulation, improper maintenance, very bottom, extrinsic seating, intrinsic seating, pathogen migration can easily occur, with dressing changes. You ever seen dressings that aren't really intact in there? There's all these opportunities, of course, for these pathogens, but look to the left of the screen. Staffing demands, rushing, shortcuts, interruptions. How many times do people not get interrupted? I'll be in a patient room and I'll see, the nurse getting paged by the doctor's over there getting, trying to get the nurse. There's all this stuff going on. Very easy in this fast-paced environment that you may not be able to wipe as long as you can, wash your hands as long as you're supposed to, and you really need a fail-safe in this measure. And that's what we learned. So we looked at this back in 2012, and we hired folks to come in and help us do a lean project, and we noticed that, because if I go around as an infection control officer, they're going to say, well, there's Marty, let me go wash my hands. So instead of having that biased data, we had these undercover folks come in. They're supposed to be washing their hands in the hospital environment for at least 15 seconds. And when you look at the mean time right there at the big X, this is what we got. So 6.3 seconds was the average time to wash your hands before touching a patient. And that's out of 791 observations there. So if hand hygiene is not going to do it for you, now look at your central line swab behaviors. So if you look at people accessing lines, whether it's peripheral, whether it's central line, how many of them at least scrub it for 15 seconds and allow it to dry the amount of time? Well, we looked at that. So our mean was 1.8 seconds. Our maximum was 6.2 seconds. This is out of 266 observations. If you look at the actual mean at the 1.8 seconds, that's pretty scary. So when we were looking at this data, we noticed that we're not washing like we're supposed to, we're not scrubbing as long as we're supposed to. So it was this time that we really realized that, we can do like some of these other things in the hospital where we noticed that CHG works all over the place. So you look at from surgical services, before a patient gets access to internal their body, we're going to use alcohol, we're going to use CHG. We use it in hand scrub, we use it in regular for patients, pre-op showering, ICU bathing. We use this in other ways. And why? Because alcohol has immediate kill. CHG has not only the kill, but it has a persistency effect that there's publications out there talking and going further into that. And when you look at it, some other things that we have tried back in 2012, you can look at the disinfection caps. So we had a problem with that because when we had our little green caps that we thought would do well for us, we didn't see any improvement. We had this for a couple years. We wanted to get to 0, and we didn't see that improvement we're looking for. So we were recommended to go ahead and audit it, do a study on this, and so we did. Out of a few hundred here, you got 97 had the caps in place that looked appropriate. We had one that fell on the floor, and they tried to pick it back up. The patient was chewing these, and when we asked the patient, they have a UTI, they're confused. They think it's M&Ms. They thought it was a green M&M. And so they're chewing on it. We had to have them spit it out, and had to get with risk, not having a choking hazard. Caps not in place. We saw this many times. Reuse of the same cap, very dangerous because nursing personnel would take the cap off, set it down. What would happen? When it's exposed to air, it's going to dry out. They would go ahead, they would administer the meds. They were trying to save money and use that same cap. Well, now it's ineffective. If you're not scrubbing in between like you're supposed to, that's not going to get and reduce the microbial bioburden that you want off those caps. Visitor tampering, we had an incident with that. What's this green thing? And they were playing with it. No scrubbing. We witnessed a few times that these people were not being scrubbed like they were supposed to. Didn't like that. And then, of course, some brown unknown substance. I did not culture it. Did not want to. But that was our go with those caps. So we got rid of the caps, and this is what we did. So we did a quasi-experimental design study. So we looked at 5 years before we made an intervention here, and then we looked at 5 years of data after. And in the whole hospital, it was 170,000+ device days. So it's a lot of data, a lot of devices. This particular study here that you're looking at is what happened with the dialysis population. So out of these, this is 18,914 device days. So you got lots of data here, and you look at what we did. We removed the 70% alcohol wipes, and we removed the disinfectant caps from the unit. And we replaced it with that single little wipe, the alcohol 70%, and then of course the 3.15% CHG. That's it. So before they access their central lines, their dialysis ports, everything, that's what they're going to use. And so this is what happened. 5 years worth of data, 2008 to 2012, 1.45% infection rate. And that's actually pretty decent in a high-risk population like dialysis that often can easily get infections. Post-supplementation, this is not a year or 2 years, y'all. This is 5 years worth of data, 0.51, and it's sustained. Okay, right now, I haven't published it. We got new stuff coming out. We're in year 6 of this, and still lots of great rates. It's just amazing how this has worked for us. So you look at statistical significance. You can plug this into the CDC's calculation here for the IDRP value, and it is statistically significant at 0.04. If you look at the numerator going down from 11 to 5, there's where you would get that different rate. And so we've done very well with this, sustained, and I'd like to thank you for listening.
Thank you, Marty. And finally, we have Joan Hebden. Joan received her BSN and MSN from the University of Maryland School of Nursing. She's an independent infection prevention consultant and research coordinator. She served as the director of infection prevention and control for 28 years at the University of Maryland Medical Center in Baltimore. And this year, she is the recipient of the 2018 Shea Advanced Practice IP Award. Please welcome Joan Hebden.
Tight up here.
Yeah, there we go.
Good evening. I'm delighted to be here to present some work from 2 individuals who are leaders of infection prevention programs that took on the journey of attempting to reduce their central line associated bloodstream infection rates as well as any of their healthcare onset bloodstream infection rates. The first paper I want to present is one from Barbara Taylor Barbara and her colleague Brittany are individual infection preventionists that work at Ascension St. John's Health System in Tulsa, Oklahoma. And in their particular study, they actually were tasked with reducing their CLABSI rates specifically. But as you can see from their design, which is detailed here for you, they actually did use the Prevantics device swab, again, chlorhexidine alcohol, on both their central venous access devices as well as their peripheral IVs. And this was done house-wide in a relatively large facility. You can see that they are a 705-bed facility with 5 intensive care units and a level 3 neonatal intensive care unit. So they had a goal specifically of a 5% reduction in their CLABSI infections, but as I mentioned, they actually were very interested in reducing overall healthcare onset bloodstream infections because, as we know, needleless connectors are used not only on central venous catheter hubs, but they are also used on peripheral IVs. And there's a lot more attention, some of which has been highlighted here at this meeting, around the contribution of peripheral IVs to healthcare onset BSIs. So we're interested in preventing all of these infections. Again, this was very similar to Marty's paper, quasi-experimental pre-post intervention. And essentially what they had was a CLABSI rate that they were not happy with. And they looked at the pre-intervention period as being January 2015 through September of 2016. And then they looked at a post-intervention period when they were using the Prevantics device swab for scrub the hub of the needleless connectors from October 2016 through December of 2017. As I think has already been highlighted, one of the advantages of the Prevantics device swab is the 5-second scrub, 5-second dry time. I think many of you are probably familiar with the challenges of the nursing staff in terms of a 15-second scrub with an alcohol pad for each access of the connectors. So one of the true advantages of a product like Prevantics is the 5-second scrub time. They did a fair amount of education around this. Again, Peggy and Marty both have emphasized that there is a need whenever you're doing an intervention to ensure that the clinical team is aware of the change and is educated on instructions for use of the product. This was done at orientation for the employees as well as in daily safety huddles. Many of you, I'm sure, are part of multidisciplinary teams within your facility where you have a focus on the reduction of bloodstream infections, and it's very important to ensure that there is a continual reinforcement when a new product is brought in, not only about the value of the new technology, but how to use it, and to report back the outcomes. They did not make any changes during this period of time with insertion practices. They were using a chlorhexidine alcohol product for insertion, as is recommended by the CDC in the Care of Intravascular Catheter Guidelines. But they did not make any changes as it related to dressing practices, for example, any new needleless connector being brought in. And they did share with the nurse managers as a surrogate for the product utilization, the amount of product use by unit. And here you can see the data. This is data based on 1,000 central line days. I think all of you are aware that this is the recommendation of the Centers for Disease Control to look at your device utilization, and that is done by there being collection of a denominator on the number of patients that actually have a central line in place each day. We are beginning to move towards standardized infection ratios, But in terms of doing a comparison of the outcome data, many of these quasi-experimental designs will use per 1,000 central line days as the metric. Pre-intervention, they had a rate of 0.76 per 1,000 central venous catheter days, and that was reduced to 0.42 with the intervention. You can see that that resulted in a 45% reduction in their collapse rate, which was statistically significant at 0.04 as the p-value. The one thing I would emphasize is that it's very important when you're comparing two different time periods as it relates to these rates to ensure that you don't have a change in the utilization of the devices as a potential bias. And so they did look at central line utilization, and that remained consistent for the pre and post-intervention time period. And they also pointed out that 7 of the 12 months that they were observing for their post-intervention period, they had 0 central line associated bloodstream infections. Additionally, it's always important to point out limitations when you're doing these kinds of project improvement initiatives. And they did point out that they did not remove alcohol swabs from the nursing units during this period of time. So they cannot be absolutely certain that they didn't have individuals who may have slipped back to using alcohol as opposed to the Prevantics device swab. However, it is important to think about that when you're bringing in a product, because many individuals would think, well, we can't completely get rid of alcohol swabs because we use those for other reasons. One of the things I'd point out is that the cleaning or the disinfecting of blood culture contamination or removal of contamination from the bottle tops for blood culturing, Prevantics has been approved for use there as well. So it isn't necessary to have the alcohol swabs around for that particular purpose, and I just wanted to point that out. They did not really perform compliance audits either in terms of observing individuals as to how long they were actually scrubbing the hub, or whether, again, they used the Prevantics device swab versus an alcohol swab. In conclusion, they did, again, find a significant reduction in the central line associated bloodstream infection rates at this facility with the adoption of the Prevantics device swab for scrub the hub. And also, they had an estimated cost savings of $706,000, which is not, anything to ignore. But I also wanted to point out that the way they came up with the cost savings here is not only by looking at the reduction in their actual infections and what an infection is estimated to cost. So they used $33,000 approximately per CLABSI because that has been published as the cost of the management of a central line associated bloodstream infection. But they also took into account the fact that they had an avoidance of this 355-day excess length of stay that is associated with these infections. And this is very important because when you have individuals that have to stay in a hospital for complications, whether it be for infection or any other complication, a thrombotic complication, for example, there is a loss of that bed for administration to admit a new patient to. So some of the economics that you're going to begin to see in the literature, and this has happened already in the last probably 5 to 10 years, is they've begun to look at this excess length of stay in their return on investment analysis because they want patients in those beds. They want to be able to admit patients. And when someone has a complication, they're in the hospital obviously much longer. And then lastly,
I'm sorry, Joan.